Hello, everyone. Today, I'm honored to welcome Dr. Anders Sorensen to the show. Dr. Sorensen is a Danish psychologist, researcher, and international expert in psychiatric medication withdrawal and mental health recovery. He is widely known for his work helping patients safely taper off psychiatric medication and for his deep understanding of protracted withdrawal syndromes. Dr. Anders has worked with hundreds of patients navigating long-term antidepressant use, difficult tapering processes, and severe nervous system dysregulation. And today we are going to explore one of the most misunderstood topics in psychiatry: what really happens during withdrawal, why some people suffer for months or even years, and how to survive and even grow during that period. Dr. Anders, welcome to the show. I'm really glad to have you with us today.
I'm glad to be here. Thanks so much. Everything we can do to spread knowledge, right, about these things.
To start with the first question, how do you define withdrawal? When you use the term psychiatric medication withdrawal, what are we actually referring to?
With withdrawal, yeah, it's a very debated concept. I think it's pretty simple. Withdrawal is communication. This from the beginning, these symptoms, withdrawal symptoms from psychiatric drugs, are often way worse than we've been told, and what doctors' guidelines still continue to tell them. And that's what tricks people into believing these drugs are so effective and that they still need them, because every time they try to stop too fast, and we'll get back to that, they get symptoms, they get worse, and some of these symptoms may look like their original condition or the original reason for starting the drug, which can confuse people. But withdrawal, as a mechanism, is the mechanism of physical dependence, meaning that if you take these drugs over long periods of time, your body starts adapting. So this all goes back to how the drugs work. Actually, it's impossible to talk withdrawal and tapering without talking a bit about how these psychiatric drugs work. And fortunately, I would say it's actually pretty simple. Now, obviously, psychiatry hates when we say that because they really want them to be very complicated, advanced, fancy treatments. They're not. They're rather primitive treatments. So what psychiatric drugs do is they're all made to enter the brain and nervous system. They cross the blood-brain barrier. And then, long story short, they're designed to seek out and block or activate certain receptors. That's even in the name, receptor, to receive. It's the part of the nervous system, the brain, that receives signals from other cells. And what psychiatric drugs do is they seek these out and block them or activate them. And what we have to understand is that while serotonin and dopamine and GABA and noradrenaline and all these neurotransmitters, they're naturally occurring in the body, but the drug itself is not. And the body knows that. It can detect that. So it starts adapting, compensating, working against it. So what we see is that if you say you take SSRIs, antidepressants, you raise serotonin and all sorts of other things, but let's just keep it to the main story. You raise serotonin. What happens over the long term is that the body detects that and starts doing the opposite. So it reduces its sensitivity, and that's dependence. So we're talking about a new homeostatic set point, really, for the body. Let the body to expect the presence of the drug. And that's fine as long as you keep taking it. Then you just have the effect of the drug. But coming off the drug, by definition, means provoking this homeostasis, because every time you reduce the dose, the body starts adapting to that lower dose, and that's a process. And withdrawal, this became a rather long answer, but withdrawal is just if you give the body too big a task at once for it to fix. So when you reduce the dose, it starts adapting. But if that imbalance between what the body had come to expect and what it now gets at the lower dose is too large, then the body will kind of have to send symptoms for a while, and that's the definition of withdrawal. It's really just when a drug leaves the body faster than the body can adapt. Then there's this period in between where it will send symptoms. And the reason why I call it communication is that the body's initial response when we change a dose will be to try to get us to take the drug again to reestablish the balance by sending symptoms. But if they're tolerable and if we overhear them for long enough, then they stop.
Okay, great answer. So could you walk us through the different types of drug withdrawal? Are all drugs are all withdrawal are the same, or what is the different types of drug withdrawal out there?
Yeah. So what happens? Really, the principle is this simple: whatever we're doing to the body's doing the opposite. That's its way of maintaining that balance. And it's the same mechanism that kicks in when we reduce the dose. The body cannot not try to adapt. But if you give it too big of a task, it'll still try, but it can't keep up, and that's when it sends symptoms. So usually, just to say that when we're tapering hyperbolically, and we'll get back to what that means, and slowly, we can use increasing the dose. We can use increasing the dose as a tool. It's a strategy we use, because even though we have all these fancy graphs and knowledge about withdrawal and dependence, there's always this element of unpredictability when it comes to tapering off. We never know exactly how much we can reduce the dose at a time without causing withdrawal. So, and within those barriers, it's perfectly normal to have to increase the dose again. And then it works. Like, again, withdrawal is communication. It's your body screaming for the drug, not because it likes or wants it, but because it has adapted and nothing else. So problem is, and that we would call acute withdrawal, like the acute reaction to an imbalance or dysregulation caused by reducing the dose. And within some, let's say, days or weeks, sometimes months, if you increase the dose, symptoms just stop. They resolve because the body gets what it needs, what it has adapted to. But there turns out to be, and that's acute withdrawal. And it even though we call it acute, and can be a bit delayed because it's all about the half-lives. Remember, if you reduce your dose today, it takes some time, depending on the half-life, for the drug to actually reach that dose. So sometimes symptoms can be late for a couple of days, sometimes weeks. But what we call, so that was the acute withdrawal. Protracted withdrawal, to me, really just means that if you stay in severe withdrawal for too long, and people do that because they're not told that it's withdrawal. In fact, a lot of people are deliberately told that it's not withdrawal, that it can't be withdrawal, because their guidelines tell them that symptoms are mild and self-limiting and last about 2 weeks, which is the core problem. So a lot of people, unfortunately, end up staying in severe withdrawal for too long without knowing it. And that's where the protracted element comes in. So protracted withdrawal, it's even in the word, it's very debilitating, severe symptoms that do not respond to increasing the dose. It's still withdrawal, but you've stayed in it for too long that it became not permanent, but and not chronic, but lasting for a long time. So we talk about this window of reinstatement, you could call it. There is an undefined window of reinstatement where if you resume the previous dose, symptoms will stop. Sometimes the same day, sometimes within hours, sometimes it takes a couple of days. Now, protracted withdrawal is when you exceed that window of reinstatement, which is undefined and obviously varies by people. Because now you're in a situation where it's still withdrawal, but your body will not accept the drug anymore. So even though you started, symptoms do not resolve. In fact, sometimes it makes it worse. I hope that's an explanation to the protracted element is to stay in severe withdrawal, if you ask me.
Yeah, when I was planning to make this episode, I just wanted to talk about the most hard element in dealing with psychiatric medications.
Yes.
And I believe there is so much suffering happening in this specific area because you don't have many tools to give these people. So I wanted to dedicate this episode to,
of course,
to talk in full details about protracted withdrawal and how we can help people who are already in this stage, and the reinstatement of the drug doesn't help them at all. But I am sure that we need first to tell people more about hyperbolic tapering and how to what makes protracted withdrawal happen, and how to prevent that from happening in the first place by explaining the science of hyperbolic tapering and receptor occupancy and all of the wonderful things you talked about in your beautiful book.
True. Thanks so much. Yeah. So it's really, sorry, it's flu season in Denmark. Sorry. So it's really two different related, but rather different conversations, right? One is, how do we taper to avoid severe withdrawal, including protracted withdrawal? That's one thing. How does the body want us to remove this drug gradually and slowly? That's one thing. And the other thing is, for those who've already tapered too fast, and that's a lot of people, again, because the guidelines haven't updated. So they're still advised to just come off in a couple of weeks, maybe months, half the dose, then stop, maybe skip doses, all this rubbish advice. So, and what do we do when you find yourself in severe protracted withdrawal? There's two different conversations, but let's start with the tapering. Yeah. So for those who haven't gotten into protracted withdrawal yet, again, two things. One thing is the adaptation and the dependence. And when we just describe these withdrawal symptoms, they're incredibly severe. That's the whole point. But remember, tapering is the solution to that. So tapering is the solution to withdrawal, and withdrawal is the result of dependence, the body having adapted to these drugs. So to avoid or minimize these symptoms, what we do is we reduce the dose gradually and slowly towards zero. That's why it's called tapering, in steps that the nervous system can handle without going into withdrawal. Because remember, the withdrawal symptoms reflects how much you've disturbed your brain chemistry with a reduction. And the obvious question becomes, well, how much to reduce the dose at a time? And this is where the hyperbolic tapering enters the picture. Because the reason why that's complicated and simple at the same time is that how much you can reduce the dose really depends on what dose you're currently on. So maybe let's describe, because hyperbolic might be a new word for some people out there. Hyperbolic is it's a shape, really, as a hyperbola. So what happens is the drug blocks receptors. So obviously, when we come off the drug, we want whatever the drug's doing in the brain to reduce gradually. That's the whole point. Problem is the dose in itself, the dose in milligram that you may be more familiar with, and that's on the box, it doesn't really tell us a lot about how much the drug does what it's supposed to do in the brain. So what happens is that we can measure this in a brain scan, and we did. We can measure the effect, not the experienced subjective effect, but the biological effect in the brain. Because when we can measure how many receptors there are, and then we can give a drug and measure how many are blocked. Now, if you plot on a graph dose in milligram against occupancy, which is from 0 to 100, you will see that that's not a straight line. If it's visual, we could maybe plot it here.
Yeah, I will. In the editing, I will put the graph
because
in the editing of the video. Yeah.
Perfect, because that makes it easier to describe for me,
Yeah.
because it's very visual. So what you'll see is that this graph of the effect, the relationship between dose and effect, and it increases rapidly in the beginning, and then it kind of plateaus. What this means is that the majority of the effect of the drug is packed into a surprisingly small part of the dose. So say the difference between, and therefore that part of the dose needs to be tapered slower. So hyperbolic tapering means following these graphs all the way down to zero. And that means at least two things. It means sometimes if you're well on the flat side, if you're above the plateau, sometimes you can actually make some bigger reductions, some bigger cuts in the beginning, 10, 25% reductions. And then I guarantee you there will be a point where you make a reduction that even though it wasn't bigger than the previous ones in terms of milligram, it suddenly hits much harder. And that's when you found that bend on the curve. It means that now the body reacts stronger to changes. So let's say Another way to say it is in the reverse. The difference between not taking 0 milligrams and say 10 milligrams is huge in the quote lower dose range. And then then add 10 milligrams, there's still a difference between 10 and 20, but it's way less than 0 and 10. And then it's what we'd call diminishing returns, meaning that for every 10 or 1 or 5 or what your dose range is, milligram you add, there's less of a difference. Now, it doesn't mean that the drugs are stronger at smaller doses. Obviously not. It means that the body can detect smaller differences in the lower dose range. So the less medications in your system, which is a good thing because you're coming off, the more the body can detect those differences. And this is why, this is the core argument behind hyperbolic tapering. And it's just called hyperbolic tapering because what we're trying to do is follow that curve all the way down. Because remember, that curve shows the effect in the brain. It shows what the body has adapted to, not the milligrams itself. So, and this is what forces people, once they're at that very steep end of the curve, this is what forces people down to the 10, 5, 3, sometimes 1% reductions, which sounds insane when you don't see these curves. But once you understand these curves, it makes perfect sense because the difference is so huge in the lower dose range. So, and the way to follow these rule of thumb is that we have to make the reduction smaller and smaller towards 0. Mm-hmm.
Yeah, I understood.
Was that an okay description of?
Yeah, it's perfect. Yeah, how when I made a video about this topic for the first time in Arabic on TikTok, it's reached near 1 million view because no one ever heard about it. And when I read it in your book, I just knew that I must tell people about this because there's so much suffering out there and no one understands why he is suffering from his tapering process. And he trusts his doctor. His doctor tells him to just have the dose and take it for 2 weeks, then have the dose again and take it for 2 weeks and everything will be okay. So,
exactly. That's still there.
And it's the doctors tell people that you just relapsed into your main illness. So could you please tell us how this is not really relapse, but it's just acute withdrawal?
Exactly, that's the main thing.
Many people get misunderstood about this topic. Yeah,
it's the main thing. So first of all, there's a lot of suffering and there's a lot of unnecessary suffering.
Exactly.
Going into this field, I'm a psychologist by training, going into this field profession, I knew I would deal with a lot of suffering. That's kind of what we do as therapists, but I had no clue I was going to deal with so much unnecessary doctor-harmed suffering, really. And that's the sad part. And I think that's what makes us, including you, I can see, and me in this field, so motivated and angry at our patients' behalf. So there's a lot of unnecessary suffering. And really, because now it might sound like we blame the doctors. Some doctors should listen more to their patients, definitely, and they should update themselves. But really, it's the system behind. I would insist that it's the system behind the doctors who haven't updated their guideline. That's the true culprit in this. Mm-hmm. Anyway, so yeah. Most people haven't heard of this hyperbolic graph before. It's news to them, but they can relate. Like when they compare that to their actual experience of making some reductions, and most people by definition are on too high doses. It's another problem we could talk about for an hour. We use way too high doses. And imagine being on just a normal standard moderate to high dose of some antidepressants, way above that plateau. And so you start hearing, okay, there's something called withdrawal, and half of the people get it and half don't. What category am I in? And then you start making some reductions and it goes fine and there's no symptoms. And woo, I'm one of those who don't get withdrawals. And then it's just because you haven't gotten to the steep end yet. You've only removed a part of the dose that had no effect. Therefore, it could, of course, be removed without causing problems. And then you get to that cut, usually at it's individual, the graphs are the mean, all that, but usually around that bend. Then it just hits harder. And then the problem, because your story, and maybe you weren't told about withdrawal, is, well, then, as you say, your mind starts, maybe yours and your doctor mind starts interpreting this. What is it then? Well, then it must be a a relapse. So this is the core problem, is that symptoms overlap.
Mm-hmm.
A lot of the withdrawal symptoms are the same as depression, anxiety, stress, psychosis, even various mental health conditions. So I used to say like this, that if withdrawal from psychiatric drugs was only physical symptoms, dizziness, lying on the floor, sweating, nausea, headaches, brain saps, symptoms clearly unrelated to mental health, this problem wouldn't exist, because it would be clear to everyone that that's not withdrawal. No, sorry, that that's not relapse, that that's a withdrawal. But because the symptoms overlap so much, withdrawal reactions can also be emotional, cognitive. It can be racing thoughts. It can be depressed moods, fatigue, intrusive thoughts. It can be anxiety, irritability, mood swings. That's where the problem enters, because if your stupid document tells you that withdrawal is mild and self-limiting and lasts 2 weeks, well, then on day 15, and if the symptoms are more severe, which they often are, then it by default gets categorized as relapse. And the problem is, well, again, remember, if you reinstate pretty quickly, symptoms do resolve. And that then creates this, it's what tricks people into believing, both themselves and their doctors, that they still need the drug. And yes, if we think that the symptoms caused by coming off the drug is the effect showing, the lack of the effect, the absence of the effect showing, well, then these drugs will look incredibly strong, right? If it can keep those kind of symptoms, withdrawal symptoms, at bay. So that's really what tricks people. It creates this illusion of effect that every time you try to stop, you get symptoms, and then you resume the drug, and then you get, well, back to where you were before. Mm-hmm. So the main problem, I would say, is that these symptoms look alike. And misinterpreting the two is important, because it'll look like you still need the medication. And sometimes, remember, it can be a huge decision to come off your medication. Maybe you've done the inner work, some therapy, a crisis has passed, you changed something, you've done some work, hard work, and finally feel ready to make it without the drug. And then, because you taper too fast, you get into withdrawal, not knowing that it's withdrawal. And it can completely mess with people's hard-earned, positive stories about where they were. And it all boils down to withdrawal not being correctly identified. I also want to say that the symptoms, I write about this in the book too, and as various articles, it makes sense when you understand what withdrawal is, like the emotional symptoms make sense. For example, it makes sense to me that you'd get low mood, for example, because the body just treats the disruption from the reduction as a threat, really. That's why anxiety is there too. It's a very primitive organism. The body just thinks that something's wrong. And in fact, that's what a lot of people will tell you when you ask them to describe their withdrawals. It feels like I'm in a scared body. I'm not scared. I can't point to anything that I worry about. It's not that talk I'm going to give on Friday, or that party, or that date, or that something. They can't point to something causing the anxiety naturally, but their bodies feel scared. And it makes sense because that's how the body reacts to us intruding into such deep territories as the brain, as the nervous system. So it makes sense that the body just sends signals as if there's something wrong. And we experience that as inner restlessness, anxiety, intrusive thoughts, worries, a state of hypervigilant and low mood. Because you're not supposed to sit around and have fun and be motivated and joyful and sleep and be happy if there's danger ahead, right? It's a completely understandable mechanism that the body turns up the anxiety and turns down the mood, because you're not supposed to have access to your positive moods if there's danger ahead. Problem is, there isn't any danger ahead. So if you don't know, you'll start looking at your life and saying, what am I doing wrong? And what happened to explain this sadness? So again, and we can go through every withdrawal symptoms and it would make sense. Just one more, the fatigue, which some people experience as actual fatigue and being tired, and as brain fog, inability to concentrate, also makes sense. excuse me for the long answer. It's just important, and I really
No,
have
take your
to.
time.
Thank you. I really want to not. One thing is just stating, oh, withdrawal symptoms include psychological and emotional symptoms. I really want people to understand why, because it helps people not ruminate, not worry, but sustain and persist through the symptoms until they stop and leave them alone, as I call it in my book. Fatigue is obvious. The body only has so much energy, and it's prioritizing it. And I think fixing withdrawal or readjusting receptors is high on the body's hierarchy. So it prioritizes this over other things. So it takes a lot of energy that we're not supposed to go around and use all our energy on that, but the body prioritizes it. So obviously it has to make us like, where does it take the energy from? It doesn't have some infinite pool of energy. It takes it from us and our mood and our energy. So fatigue is completely normal. And so this idea of the body prioritizing it really is what I find a lot of people can find some compassion and understanding towards themselves instead of identifying with the symptoms and thinking they're long lasting. Like what do you call it? Fever. A good old fever. That's the body prioritizing burning bacteria over your mood. It's not so important that you're happy and in a good mood now. It's less important. So it prioritizes burning bacteria by turning up the heat and deprioritizing how we feel. And the body knows how to do this. It's the exact same mechanism with withdrawal. I can't remember what you answered, but I'm sure.
No, it's fine. We can go on that same tangent. And and also very huge element of the suffering is that the physical symptoms get interpreted as I have a physical disease or I have that physical condition. So people go and make MRI and then make all lab tests and they find nothing.
They find nothing.
This is very puzzling.
And it's one thing is like sometimes at least politicians here, they need an economical argument to make change. I would really like to see how much this costs society first, because all the MRIs, all the PET scans, all the fancy biological measures, all the consultants and special doctors, only because withdrawal wasn't defined in the guidelines. That's what makes you go into other territories. And yes, it's a good point. It's the same point, really. Some of the symptoms are emotional, cognitive, psychological. They mimic relapse or other mental health conditions. And what happens sometimes is you enter what we call a prescription cascade, meaning because the symptoms are interpreted as, your original condition returning or some new diagnosis magically unmasking itself right when you stop your drug, then the solution is more drugs, and so the story goes. But the same problem is with physical symptoms, and this is a point in itself. We talk so much about withdrawal and relapse looking the same, and they sometimes do, but other times they clearly do not. And I think we should talk more about that too. Sometimes the symptoms are completely different, the physical symptoms. But they're also not described in the guidelines. So the same problem occurs. And I've seen completely different symptoms also called relapse because the doctor isn't trained in withdrawal symptoms being so diverse. So I'm convinced that if doctors spend 2 minutes with their clients curious about what the symptoms are and how little they resemble the underlying condition, it would be clear to them that it's not withdrawal. But yeah, for some people, the main problem definitely is this me underneath the drug or is it withdrawal? And we fix that by resuming the dose and tapering slower, basically. Another group do not have the slightest doubt that this is not a relapse. They have, it is withdrawal, and they know that. Their problem is how to get through it. Again, back to hyperbolic tapering.
Mm-hmm.
Yeah.
So to make best use of our limited time here, I want to move to the practical practical steps of like someone will be asking you, unfortunately, I tapered in a completely wrong way. It's 3 months. 3 months from the last dose, and I am already in. I can't. Reinstatement will help me here. In most cases. So tell me the practical steps on how to manage what the hell that I'm going through right now. So can you walk us through the different things that you use practically to help your patients manage that? We need to talk about everything: the psychological tools, the supplements that might help, anything, any possible psychiatric medication that is used. I want to walk through every possible tool that can help these suffering souls.
Let's do it. And what we talked about already, there are plenty of free resources out there on how to taper hyperbolically. So let's leave that for now. So this is the situation where you've tapered too fast and reinstating did not work. Because if reinstating works, you just reinstate and taper slower. Okay, so this is the situation where that does not work. And maybe it even makes it worse. I should add that. And this is why we should be careful. When you're in protracted withdrawal and you contemplate increasing the dose, there are really 3 scenarios. Either it works, fine. You stabilize, taper slower, problem solved. And that could take years, obviously, the taper slower. So it's not that it's easy, but in terms of protracted withdrawal, it's solved. Or it does not work, meaning that you increase the dose and nothing happens. Okay, then it doesn't make sense to take it. Then the nervous system is stuck in withdrawal mode. Or it makes it worse due to something called kindling. So it's that third option that makes it so that it's not completely free to try increasing the dose, because sometimes what happens, withdrawal is a shock. We have to think of it as a shock to the nervous system. And one thing is it causes severe withdrawal, and another thing is that in an attempt to protect itself, the nervous system can get what's called kindled, meaning now it becomes hypersensitive to the drug itself and other sorts of drugs. And that's a way to say that's really unfortunate, because now part of your body reacts to you not taking the drug, withdrawal, and another part of your body reacts to you if you take it again, making it even worse. And so that's why increasing the dose or adding other medications is not necessarily a tool to severe withdrawal. Sometimes, and it's not a recommendation, sometimes benzos can take some of the, on the very worst days because they're such strong drugs. But other times the benzo also triggers the kindling reaction. So I hope kindling makes sense. It's really just the body putting up the big guardrails. It's a pissed off nervous system, and it's trying to make you not interfere with it further. And one way it can do that is to make itself hypersensitive towards the drug that caused the withdrawal, but also towards other types of substances, other psychiatric drugs, but even things that wasn't a problem for the person before: caffeine, alcohol, sugars, carbs, sweeteners. And sometimes not the solution, but a way to help protracted withdrawal is to do this, sometimes hard work of an elimination diet, to look for things that are perturbing, irritating the nervous system. And the tricky part is that these can be things that were never a problem for you before. Maybe you've drank caffeine for years, and suddenly, because you shock the nervous system, it starts reacting to it. So yeah, I'll get back to that, but maybe I'd just like to mention some of the symptoms of protracted withdrawal, because I realized we didn't do that at all. We just talk about it.
We missed that part. Of course, we need to talk about that.
I just talk about it as if everyone knows what protracted withdrawal is. And the list is basically the same as the list of withdrawal, because protracted withdrawal is that the withdrawal reaction gets stuck. But what we see most often would be what people describe as brain fog, which is when poor concentration or difficulty concentrating isn't enough, we call brain fog. Memory impairment, slowed thinking. Some people find a difficulty finding the words. Dizziness. Some people describe it like walking on a boat. Head pressure, anxiety, which some people, it reaches the point of tremor, internal tremor, and akathisia, which is a medical word for, it's a Greek for can't sit still, inability to sit still. And it is we shouldn't rank them, but it's definitely one of the worst withdrawal symptoms, because there's no peace, there's no quiet, there's no calm, because your body is so convinced that there's danger ahead that it constantly sends symptoms. Brain saps, sweating, temperature dysregulation, all the emotional stuff we talked about, severe insomnia, which also makes sense. Like the body kind of doesn't want us to sleep when there's danger ahead. Like, why sleep? That's very dangerous. Vivid dreams, emotional ability, crying spells, all these things. Muscle pain, some people get flu-like symptoms. I could go on, but I think people get the gist of it here. So we can't treat protracted withdrawal because it's so deep. So we're limited as to what we can, we can't intervene the nervous system and fix it. It's the other way around. The body knows how to fix it and it wants to fix it, but it takes time. So my main message is, I'd like to stress that it does heal. It's not permanent, but the time frame can be very long, sometimes resembling those of concussions, where it's perfectly accepted that it can take years for it to adapt. So sometimes a good long hold is what the body is calling for. And remember, this is a situation where we know that increasing the dose did not work. Sometimes it's just time. And it's such a vague advice, I know, because the symptoms can be so debilitating. But there's two different conversations here. One is trying to understand, what is my nervous system calling for? And sometimes that is time, in the exact same way that we'd approach it in acute withdrawal. It's just way more severe and longer. So, and this is really where there is an overlap with the chronic pain community, actually. And the reason why I hesitated was that I don't want people to think that this is chronic, but the chronic pain community and the withdrawal community, because the elements of how do you accept this? How do you allow? How do you not add fear? No one wants to accept this. It's a grieving process for most. Nobody wants to accept this degree of limitations. But so what usually happens is, because it's so unpleasant, of course, we start fighting it, actually. We start resisting, suppressing, trying to, going back in time to the event. Well, the mind starts ruminating, what could I have done differently? Constantly revisiting the event as a way to solve the problem. And we add a lot of thoughts, and understandably. But my point is that some of these attempts backfire. And that's where because it adds distress on top of withdrawal. And a lot of what we do with people in protracted withdrawal is identifying that layer, which is psychological. It doesn't mean that the withdrawal is still absolutely real. It's not in your mind. But sometimes our attempts to fight it and resist it adds distress. So this is where acceptance and allowance and all those things you just don't want to hear about in the beginning. There's a process for most people to accept and allow. And in that way, figure out, how can I be with these symptoms because they're there? I hope that makes sense, that sometimes part of it's helping, it's the psychological mechanisms. And it can be the hardest thing you've ever done because the symptoms are so deep. So I'm just trying to put out the landscape here. Sometimes increasing the dose works fine. Sometimes holding really works. It's just a matter of time, because we can't intervene. We can't tell the nervous system to adapt faster. But we can learn how to be with those symptoms while they're a part of our lives. And we can practice discovering how to do things with symptoms. And I know this will sound impossible to some people. So I can't do that. But I promise you, there are ways, and there are people out there who can help you do that, how to navigate it. And it's a process for everyone to get through that resistance, because it's so unpleasant, and because it isn't okay, and because it's unfair, and because it's so deep inside the body. But that doesn't mean we can't move things around. Now, that's another one. And remember, it can sound, accepting and allowing will sound to some people as as, resigning and giving up. That's not the part. It's just something we say that while the symptoms are there, maybe for months, maybe for years, what's the best way through? And that is definitely to learn how to control attention despite symptoms. So there's some psychological ones, and there's some increasing the dose, there's some waiting. And it works. Like a good long haul can definitely work. And then there is this idea of reversing it. Like we can't speed up the process, but we can sure as hell, we can give the body the best conditions to heal.
Yeah, I have a question here. Sorry to interrupt.
No problem. No problem.
It's in psychotherapy, it's really important to highlight the concept of agency, and that
Yes.
I am not a victim.
Yes.
And I have a role and responsibility towards my recovery. So
yes.
I want to ask this question. The way I interact and my own reaction to what happened to me, does it affect the speed of recovery, or can it slow or fasten recovery, or can I have agency and contribute to my own recovery, or I just passively wait and time will heal everything? Because this is very, very important in the psychological aspect of it.
I think yes. And there's a fine line between saying this and making it sound like it's all in your head. Because the more we say, some people will hear it as this, the more you can do, the more you're telling me, the more I can do, the more you're telling me that it's just in my head and my fault. And that's obviously not the case. The core is absolutely biological. It's in your body. It has nothing to do with what you think about it or how you relate to it. It's there, and we can't move it. Only time can heal that. But because it's so unpleasant, the natural human thing to do, because that's our basic instinct to rid ourselves of pain, is to fight it. So the things we do towards it can cause problems, and just removing those can be a huge game changer for people. Now, and if you're asking whether this has an actual effect on the withdrawal, I think yes. And again, it goes back to the priority thing. If you worry and threat monitor, constantly check in to see how you feel, which you do in the beginning, and you stress a lot, worrying is an active thing. Worrying is engaging with a what if thought, and it's engaging with these catastrophic scenarios in ways that could feel so lively that it does actually have a real effect on your biology. That's why you can get anxiety. Like the natural route to anxiety is to worry. So our mind sends us a what if this, what if that thought, and we latch onto it. We start worrying about it. We prepare, we imagine scenarios in our minds. And that's what creates the anxiety, because the mechanism is as simple as this. And I promise you, I will get back to why this relates to withdrawal. The body cannot distinguish between what's actually happening, the tiger in front of you, or what you're vividly enough imagining. It'll react the same. So obviously, worrying a lot, overthinking a lot, overanalyzing a lot, projecting yourself into the future a lot, and the despair that causes, we can only expect that to add, in a very real biological sense, on top of withdrawal. Exactly. Because again, I think it's this, I'm sorry for returning to it, but it makes sense. It's, again, this hierarchy. It's prioritizing. So if the body has to fix withdrawal and fight the tiger you're imagining, it isn't there, but you're imagining it enough so that it becomes a threat. Well, then again, we're in a situation where the body has to, distribute its energy. And obviously, to me, it's obvious. It makes sense that it has to slow down the readjusting receptors, the fixing withdrawal, if there's a tiger in the room. And that's why we'll see, if I understood your question correctly, are there psychological elements and ways of being and relating to withdrawal that actually prolong the process? And I firmly think there is. So part of the process is, first of all, to understand that it is withdrawal. Check. You're not wrong. Nothing's broken. You're not crazy. You're not ill. You're in withdrawal. understand the mechanisms, and then understand that our intuitive response to being in such pain and such unfairness is to try to do something to it. And one of those things is to try to resist it and constantly monitor for it and worry about it. It's so difficult for us humans to be in pain without also, projecting it into the future. What will this mean for me and the rest of my life? And that's the worrying. So if we can help people to have these thoughts, and they will pop up, of course, how long is this going to last? What is this? Am I broken forever? Do I feel better today than yesterday? All these very, very valid questions. They're valid, and I'd love the question to them too, but that does not mean that constantly worrying about them will help you. And this is a thing some people can kind of, when we say that, it can sound like we don't understand it, but believe me, I do understand it. But just removing the overthinking element can really do a different, and that's an attention thing. I have a whole chapter about this in the book.
Yeah, this will take us to metacognitive therapy, of course. Maybe we can jump into it right now, and
yes.
Later on we'll cover some tricks and some advices about managing symptoms. Okay, yeah. So let's start.
So metacognitive therapy is a school of psychotherapy. And even though it has cognitive and therapy in it, it is just about as far from standard cognitive behavioral therapy as it can be. It's different. And I could have a long, boring lecture about that. But MCT is a school of therapy that directly targets overthinking and overfeeling and checking in and other ineffective coping strategies that tend to backfire. And it does so primarily by separating what we call a trigger thought and a response to a thought. A trigger thought is, made by our minds or brains, or wherever we think thoughts come from. It could be, what if so-and-so? That's a trigger thought. It's a question from your body. And from your brain. And when you're used to worrying, you won't experience this as two separate things. You'll just experience what if, and then trying to answer that thought. And that's the worrying. So what we try to do in MCT is that we separate the thought that just pops up from your response to the thought. And catastrophic thoughts is not worrying. That's thoughts. Worrying begins the moment you try to solve or figure out the thought excessively. And we do that mainly by two things when we're worrying. We're trying to prevent said catastrophe to happen. We try to project ourselves into the future and play out these little scenarios that, okay, what if this? Well, then I'll just do that. And this game we're playing will really have two goals. One is to prevent it from happening, or to prepare ourselves. And while we're doing that, we're sending signals to the bodies that it's happening now. Therefore, it creates stress and anxiety. And the same mechanism is with rumination. It's just the other way around. Rumination is the word gotten from what cows do in their forestomachs to food when it goes in circles, and then we think, oh, that sounds like something we humans do to our thoughts, repetitively going in circles about issues to try to solve them and find answers. It always sounds positive, like the story we'll have is, I'm trying to figure out, I'm trying to get to the bottom, I'm trying to prepare for the worst, I'm trying to figure out what to do. It'll sound positive, but it's repetitive and it's not, leading to any solutions. So metacognitive therapy, core argument is to teach people that help them discover that these are two different things. Having a thought and extending the thought, answering to replying that thought, is two very different things. And overthinking involves both. So if we can teach a person how to have their sometimes very unpleasant thoughts or triggers without engaging with them, well, what they'll experience 11 out of 10 times when they're trained in doing it is that their intrusive thoughts, the very horrible negative thoughts or impulses, can actually they can be pretty short-lived if we don't latch onto them and maintain them. And that's what we call self-regulation. And from there, and that's where the attention part comes in, when you have a difficult thought or sensation or impulse, And your job is now to not engage with it, not fight it, not resist it, not answer it, nothing in this moment. It's an attention thing because it's hard. It'll pull, drag in your attention. That's what it can do. And that's where the role of attention comes in, that we have to think of attention as a muscle, really. It's something we can train. Attention works as a gatekeeper for what enters consciousness. The two, and please just, interrupt and ask questions if you have something specific, but I always use these two examples to prove the point. For example, to prove the point that attention is a gatekeeper. I'm sure it feels a certain way, you and everyone listening, sitting in the chair or lying in the bed right now, like wherever your body contacts the world, there'll be a sensation there. I'm also pretty sure that you have this characteristic feeling, this sensation inside your mouth all the time with the tongue. It's very difficult to describe. But okay, so here were two examples of stimuli that were there, but I'm fairly sure weren't a part of your subjective experience before I said it. And in a moment, they'll be gone again. So this just proves that things can be there without being part of our subjective experience. That's attention. The only thing that changed was attention. I said the words, you paid attention to them, therefore they entered your mind. Now, so imagine being able to, first of all, discover this mechanism and use it for your advantage. Because the only difference, it's a major difference, but the only difference between these two neutral stimuli that I just mentioned and withdrawal symptoms is that they hurt. They're unpleasant. So they drag and pull in your attention. These sensations do not, because they're completely irrelevant. But remember, the body will think that that things are dangerous, so it will it has the ability to pull in your attention. So that's why, and that's what I mean with metacognitive therapy, is we can definitely learn to be in distress in ways that make it step into the background by using your attention. And it's not distraction. Refocusing outwards to something external is not the same as distraction, because distraction, there's a different goal. When we distract, we have a goal of suppressing something with something else. Then you've misunderstood attention training. This is being with that pain, having that follow you while being able to direct your attention out into the world. And what people will say, also, if you just ask them before introducing this, and actually sometimes this is the introduction to talk attention, the role of attention, is to ask them whether their symptoms are they constant, or do they fluctuate even a bit, or is it 100% constant within the day? And what most people will say, obviously, depending on how severe it is, that no, it fluctuates. And when I do stuff and that friend came over I watched a series, or I took a walk, or I had some practice thing that I had to do, symptoms tend to step into the background, or maybe they completely forgot the symptoms. And that's attention. That's just when it happened just randomly when you go about your day. Sometimes you do stuff that requires your attention, and that just proves the whole point of symptoms stepping into the background. And this is, if you ask me, the main psychological trick on how to get through withdrawal, to learn to use that.
Yeah, so we can say that withdrawal by itself is like 5 out of 10 or 6 out of 10 suffering on the suffering scale. But the psychological aspect, when it's added, it can make it 9 out of 10 or 10 out of 10 in the suffering scale.
Yeah. Mm-hmm. Exactly. So yeah, so all these, I think I'm just messing a bit with my camera here. So important point. And that I write this in the book too, that
that's a beautiful chapter. It's a very, very that beautiful chapter.
And the point is that what we just talked about applies most to symptoms that are already minimized by an actual hyperbolic taper. But so just leaving something alone or allowing or accepting can be almost near impossible in protracted withdrawal. But what else to do? Like, we have to look for things to make it as easy as possible through. And sometimes, or a huge part of that, is to spot our own resistance, our own overthinking, our own fighting with what is, and learning how to be with that, controlling our attention outwards. Yeah.
Okay. That's great. I believe we covered the psychological aspect of it in a very, very beautiful
I hope so.
way. So, but let's jump into a little bit of pharmacology here, because this is very important. I want to ask this question: why is psychiatric medications, normal psychiatric medications like adding an antidepressant, adding an antipsychotic, adding a mood stabilizer or benzo, is considered contraindicated in dealing with protracted withdrawal? Because many psychiatrists will think, well, I will just put the person on SSRI, or I will just put the person on a benzo and everything will be okay. So could you please make this point clear, or why we don't use psychiatric medications in dealing with protracted withdrawal?
Well, because it's, how do we say this politely? Because it's not a natural thing. It's not a condition to treat. It was caused by a drug leaving the body too fast. And the body was trying to communicate this to you through symptoms, but you didn't listen. And the main reason why you didn't listen was that you weren't told that this was withdrawal. But that doesn't change the fact that from the body's perspective, we massively shocked it. And we didn't react to its symptoms. We didn't react to its signals for us to take the drug again. So there's no cure for that. And as we talked about, that doesn't mean it doesn't heal, but there's no medical intervention that can cure it. Because it's not a lack of whatever you can introduce into the body with medication. In fact, it often makes it worse because of the kindling thing. Because remember, and I firmly think that we have to think of it as two different things happening. When we shock the body by following the guidelines, ironically, the body does two things. It can send severe symptoms, and it makes itself more sensitive towards the drug, because it's really just trying for us to not take it again. So part of the body is trying to make us take it again. That's the withdrawal. Another part is just harmed by the sudden shock. And that goes back to the kindling. I firmly believe that if we want to understand this, we want to understand how the body sensitizes itself to things that shocked it and other drugs. And that's why, good luck trying to cover it up with an antipsychotic or a benzo or something else. Sometimes it works because the drugs are stronger. I don't have any statistics, but I wouldn't do it. I wouldn't do it. It backfires because then we haven't understood the core problem, which was that we shocked the nervous system, and the nervous system is kind of trying to make us not do that again. And it can't talk. Well, it tries to talk with withdrawal.
Some very hard question here. If someone if someone is suicidal and you have to do something like to intervene immediately, is there any room to use any of these meds in this case, or it even will make him worse? Because this is a very hard question.
So this is the problem. First of all, I'd like to stress this is not an anti-medication thing. It's not like, oh, we shouldn't use more medication to treat withdrawal injuries.
Of course, we agree to that.
In the situation where, say, you are in protracted withdrawal, and a benzo works, or some gabapentinoid or something, use it to get through the worst days. Of course, that's not the problem. Like, I think we would do. A person in protracted withdrawal would do anything to make it stop, or at least lessen it. And if you're one of the ones who happen to respond well on another drug, we should do it. It's just we don't know who they are, and there is a risk of making it worse. As I said before, it's not just that either it works or doesn't work. Well, if that was the two only options, of course you should try everything, but it can make it worse, and it's that third option that really makes it important. So
yeah, this is what we know from the lay community, like the surviving antidepressant.com and all of these lay communities people. They say that when I added a psychiatric medication, it made it worse, and
it made it worse.
It delayed the recovery period. So this is very, very. This is the least things that anyone on protracted withdrawal wants to hear about.
Exactly.
It will delay my recovery period.
Yes, and it delays it because you're pushing it. You're basically unknowingly you're pushing germs in your finger into a wound. Like imagine a physical wound. You're standing there, you're touching it because you're trying to fix it. Like I'm trying to make the analogy of an actual physical wound. Obviously, it takes longer for it to heal if you push it, scramble it. So, and that's why the other things we talked about, time, maybe an elimination diet, like maybe you're perturbing your system with something unknowingly, that's the reason why you have symptoms months and sometimes years off. Some people even need or find that they need to go full on keto or carnivore to give their body the best metabolic state to fix this. And again, this is not, it's technically we're not intervening the nervous system and speeding something up. We're freeing up resources, for example, by removing blood sugar and glucose and insulin spikes. So I think people, and I'm biased because I've been on keto myself for many, many years and have a huge respect for it. But I actually think it kind of makes sense here. Like it makes sense that the body's preferred metabolic state would free up resources and energy and capacities to heal withdrawal faster. Whereas if the body has to fix withdrawal, again, exactly the same hierarchy ideas before, and deal with the standard Western diet of carbs all over and processed foods, of course it's going to take longer because then again you have two tasks. So that's another thing that I found helpful, and definitely do this before trying other medications because it rarely works.
So we were talking about suicide. We didn't cover this topic. So yeah.
Obviously, we shouldn't just leave suicide ideation alone and not act on it and all the things we talked about before. It's just sometimes we still have to understand that we're limited as to how much we can really do. But I see, like I work with suicidal clients all the time, having suicidal thoughts. Sometimes suicide ideation is part of the rumination process, that you're looking for solutions. Your mind is looking for solutions to an unbearable problems. And while sometimes and momentarily, that machine tends to arrive at the ultimate solution, suicide, which is, it's a solution. Technically, it's a very bad solution, but our minds can't see that. It just keeps, sending, tries to solve the problem. And sometimes it is a chemical effect of the actual destabilization. People will say that they have sudden intrusive suicidal thoughts that they never had before. Obviously, we assess the risk. And if the risk is low, whatever that means, we treat it as any other thought and help the person through. And usually the trick I find helpful is to understand and then reflect back with the person that the suicidal thought or the suicidal ideation is an expression of how hard everything is. It's really just a way of reflecting how painful and difficult and overwhelming withdrawal is. So if we can see what the thought or ideation represents and then refocus, okay, let's talk about that. Let's help you through. Let's share. Let's support you in how hard it is. So that we kind of focus from the symptom, which is the thought, to the problem that the thought is caused by. Yeah.
Okay, so
and then talk about that, and that can be relieving for some people, because the point of the suicidal thought was to reflect and share and validate how hard this is, and then sometimes it resolves.
Yeah, exactly, and the time aspect of it is really gives people hope that this pain will eventually subside. So this is very, very important. But I want to stay on a little while on the pharmacological aspect of this, and to talk about the supplements. But before jumping into the supplements, do you find some autonomic nervous system drugs helpful here? Like, for example, some people talk about Enderol. that help them with their symptoms.
What drug, sorry? What's it called?
Inderal, Inderal, bupropion.
Sorry. Yeah, I didn't. Different names.
And I was searching another. I also searching another alpha 2 receptor agonist called guanfacine. It's like it works like clonidine and all that. So do you believe that there is this autonomic nervous system medications are safe here to use, and can people benefit from these medications because since they lower cortisol and lower epinephrine and the sympathetic nervous system tune?
It's definitely beyond my expertise to know, but I can only imagine that. Well, yes, if a drug successfully tricks the body into believing that there's more calm, which is definitely also what drugs do when they work, right? In the first place, if we can trick the body into believing that there's more, whatever we call it, safety, then it would work, because that's the whole problem. So theoretically it could work. It's just we don't know whether the body would treat the drug in that way or as something perturbing it even further. So I think the basic principle of kindling applies beyond psychiatric drugs. I could imagine, because it's one body, numerous different systems, but it's one body, it's one nervous system, it's one brain, it's one system that you introduce the drug into. And few drugs are so selective that they target only one system. So it means even though you take a drug that is completely has nothing to do with psychiatric drugs, well, how do we know that whatever system that perturbs doesn't, have downstream effects on something the drug perturbed? And then you'd have the problem. So I guess the answer is vague. Yes, sometimes it might work, and sometimes it might not, and sometimes it would definitely make it worse, for the exact same reason as the one we talked about before. And we don't know, and maybe we'll never know. So there's this element of trial and error. So again, I can feel that my answer is a bit mixed, because if there's something out there that can help you in protracted withdrawal, do it, take it, because that's the problem, that we're looking for solutions to do something. And while saying that, so it's not the people who just give up, I'm also like, it's potentially dangerous, it's risky, and I'd rather point people toward the natural things and the innate natural capacities for the body to heal, if we give it the best possible conditions to heal. I think that is way stronger than any supplement you can ever take. Beyond, of course, omega-3 and magnesium.
Can we exclude? I was just going to say that. Can we exclude from this list omega-3, magnesium glycinate, and melatonin?
Yes. So those are I think melatonin is generally speaking too weak to perturb the system in this way. I haven't seen someone react paradoxically to melatonin. It might happen, but no, that's beyond category. So yeah, I would usually have omega-3 and magnesium, which most of us are deficient in, and then some electrolytes, maybe creatine. Mm-hmm. Those are fine. I've personally never seen problems with those. And it's all about understanding that the body wants to heal itself, and it knows how to heal itself. And we need to not get in its way. And we need to shift our focus from fixing stuff to providing the body the best possible conditions to heal, which includes dietary stuff and supplement and what supplements we choose. And the worrying we talked about before.
Okay, since we are running out of time here, it's like we are past 1 hour.
Yeah, it's perfect. No problem.
sorry about that. But the topic is very, 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 very rich. Rich, and it's hard to summarize. So if
we'll just do another one. If you have a lot of questions. Just write down the questions.
We totally need another episode, of course.
Yeah.
So is there any let's call it, is there any else practical trick or tips that we didn't talk about that someone would benefit from using it? Like if you would give advice from what you've seen working with all of these patients, is there anything that we didn't cover in this episode that you would probably recommend or advise to someone?
In protracted withdrawal or just in general?
Protracted withdrawal. Oh yeah, this is just protracted withdrawal.
Because it's such a unique experience, and I don't mean unique positively. I mean that nothing really looks like this. Nothing looks, first of all, the symptoms, nothing looks like that. And then add the unfairness of it being iatrogenic, meaning doctor harmed by your doctor, and how like many aspects of it makes it so unique that most people cannot relate. They can try and they can, but they cannot relate to being in it. So my main advice would be to find someone who's been through it, or who still is, but who's further than you. Because, and that's a tricky part to find these people, because, and I love the forums, and it's a huge part, you know, the withdrawal forums.
Yeah, I must create one in Arabic, because in our region, this is totally missing, and this creates a huge sense of loneliness here.
So exactly. So here you are with symptoms not recognized by your doctor, not talked about in the public discussion, and you have your own ruminations going whether you're crazy or defective or something, and no one to share it with. Then you can add loneliness on top, and whatever that means, that's not going to work. So beside all the psychological and dietary things we talked about before, natural things, share it with someone who understands, and who also understands that what you're looking for when you're describing your situation is not someone to fix it. Because sometimes what often happens is it's so distressing that it triggers the other person's inability to be in pain without fixing it. You see? And that's just the worst, because then you don't need, well, you need it to be fixed. Can't, and you're not asking for people to fix it. You're asking for people to be with you in it and listen to you. And because it's such an out of the ordinary experience, you'll rarely find that in the normal public. You'll find that in people who've been through it, and that then needs to be balanced with these horror stories that sadly you see most of online, because the people harmed the most are those who feel the most need and urgency to tell their story. So there's a flaw in the withdrawal community, and that what you'll find is mostly the worst stories, the horror stories,
biased,
which are not very motivating when you're in it, right? So you see the fine line between validating, understanding, getting validation and normalization, and then these destructive horror stories. So sometimes there is a part of the process where you kind of have to shut down all the tabs open in your forums and find someone, ideally in person, who's been through it to share it with. That can be massive change for people.
Yeah, of course. So if you would, since this all podcast is for Middle East and for Arabic population, would you leave us a message here for specifically for the clinicians and psychiatrists and people who are working in mental health field in general? Could you leave them with advice? Some message you want to leave with them?
Yes, it's simple. They need to educate themselves. And I say that directly because the system is not going to do it. Hopefully it will in our lifetime, but not today or tomorrow or the next couple of years. It's what we're talking about here with how psychiatric drugs work and how they don't work and what it means to come off them. It's so far ahead from where the paradigm is that it's going to take years, if not decades, for those two things to align. So that's why I mean it literally when we educate yourself, because no one's going to do it for you. And in the current situation, it's perfectly normal for a doctor or a healthcare professional to meet a patient that knows more about it than they do. It's not their fault. It's the system behind them, because patients are often forced into educating themselves, and they can get pretty damn good at understanding even geeky pharmacology and withdrawal stuff. So educate yourself, and I'm saying this because the knowledge is out there. We know way more about how to come off these drugs and how not to than it appears. And it's in my book, it's in the mostly deprescribing guidelines, it's on the forums, it's on a lot of different YouTubers, Joseph Witt-Doering, for example, Laura Delano at the Inner Compass Initiative. We have so many, Surviving Antidepressants, Roger McFillan. We have so many, Angie Peacock, so many people working in this field. And I'm so sorry that I missed some of you. Nicole Lamberson. We have such great knowledge about this. It's just not in your official books. So educate yourself, because it is out there, and trust your patient. I feel like saying to it, trust them when they express withdrawal symptoms that are worse than what you were taught. They're probably right. Does that make sense as an answer?
Yeah, sure. And
good.
One practical step is to have an Arabic translation of your book soon available in our region, because this will really help the clinician know more about this topic. So thank you, Dr. Anders, for giving us this time. And finally, where can people find more about you and your book?
So I'm on all the usual channels, but I'm prioritizing Substack, which is just called Crossing Zero, like the book, and Facebook and Instagram, and a little bit on YouTube. But I'm mostly on Instagram, Facebook, Substack.
Okay.
Yes.
Great.
And I'm trying to spread awareness. I don't know if that's the right. I'm trying to share what I think people need to hear in the process. So I'm trying to channel knowledge directly to the user and their loved ones. So most of what I do, hopefully, is directly applicable to people in the situation. At least that's what I'm trying to achieve.
Okay, great. Thank you so much.
Thanks for having me.